Hi friends, welcome back to my channel. For those who don't know me, I'm Chris and I'm a dermatology trainee currently working in the west of Scotland in the UK. And on this channel, I share my life experiences working in dermatology and life in the UK in general. So for the past 3 months, I've actually been doing a new job in dermatology, which is Paediatric Dermatology, where we see children with skin issues. For those who don't have much experience in pediatrics or dermatology, I have to say it is a whole new world compared to adult dermatology. And so I thought maybe I should share some of my experiences working in pediatric dermatology for the past 3 months. I have to say, children are so cute. Again, these are my personal experiences, so other people might say something totally different. So please take it with a pinch of salt. So number one, most of our referrals are due to atopic eczema. Now, atopic eczema comes hand in hand with other diagnoses such as hay fever or allergic rhinitis, as well as asthma. We see a lot of GP referrals where children's eczema is either not well managed in the community or where it's so bad that they are not responding to any topical treatments. We do see other referrals such as inflammatory skin conditions like psoriasis, lichen planus, lichen sclerosis, hair loss or alopecia, nail changes in children, as well as this phenomenon that we see quite commonly in prepubertal girls such as vulvovaginitis. GPs also refer patients with changing molds, birthmarks like capillary malformation, or genetic conditions with skin manifestations, and most commonly we do see infantile hemangiomas as well. The most common referral is still atopic eczema, and this is so commonly seen that we have our own information booklets, treatment plans, plenty in our drawers in clinics, as well as we asked parents who come for the first time with their children to fill in a questionnaire on their eczema. And this brings me to my next point, which is number 2. Parents often undertreat than overtreat their children's skin. Working in pediatric dermatology makes me realize that parents often are quite cautious when applying topical steroids on their children's skin due to the fear of steroid side effects. I find that particularly in pediatric dermatology, there is a lack of awareness and understanding amongst parents, patients, as well as healthcare professionals in the treatments we use to treat atopic eczema. In principle, in dermatology, we often encourage the use of regular moisturizers, and in dermatology particularly, we prefer ointments than creams or gels. This is because ointments are greasier and last longer than creams or gels which will evaporate quite quickly. Other things would include a good soap substitute, and we have a wide variety of soap substitutes we offer in dermatology. And lastly, topical steroids when the skin is inflamed and we need to treat the inflammation. And essentially, one fingertip unit is from the end of the index finger to the first crease, and it should cover the area of 2 adult palm sizes. From my experience working in pediatric dermatology, oftentimes parents either are not using enough moisturizers and topical steroids, or they are simply not prescribed the big tubs that we need in dermatology. I've also seen some parents asking me about miracle drugs that they've heard online or in the news to treat their children's skin. But unfortunately, eczema can't be cured, but it can be well controlled. And in dermatology at this day and age, there is a wide variety of treatments we can offer, not just topical treatments, but also tablets and injections and even light treatment. Though the more treatments we give, the more side effects they can lead to. And so if the skin is responding to topical treatments, oftentimes we want to maintain the skin barrier function by regular moisturizers, a good soap substitute, and topical steroid as and when it is required. Number 3, we hardly do skin biopsies on children, but we do lots of clinical diagnoses. In pediatric dermatology, you do get referrals of skin lesions or moles that have changed, but fortunately, majority of them are benign or non-worrying. Now, the reason why we don't do skin biopsies often on children is because skin biopsies are often quite traumatizing and distressing, and we don't want to traumatize them any further than we need to. And this often means that we really need to brush up our clinical acumen and skills in diagnosing skin lesions without the need of investigations. And this is precisely why I fell in love with dermatology in the first place. Sometimes we actually do need to do a biopsy, either because we don't know what the diagnosis is and need to find out, or the lesion itself does look a bit concerning, and we do see melanomas very rarely in children. And in this case, we can do the biopsy under local anesthetic as with any adult patient. However, if the child is very distressed, or if we are dealing with an infant, baby who is constantly fidgeting, then we can't do it under local anesthetic. And in this case, we will have to refer them to the surgeons for the procedure to be done under general anesthetic. Again, general anesthetic simply just adds a whole new layer of complexity for the child and possible complications as opposed to a simple local anesthetic. And these are some of the things that we actually need to think about compared to an adult patient where we can just do local anesthetic and skin biopsies in the department. The next point is that skin conditions can be very distressing to children. Well, let's take atopic eczema, which is the most common condition we see both in children and adults, for example. With eczema, parents complain that their children would be itching at night, scratching away, losing sleep as a result, and this can have a snowballed effect for the next morning. It can be so bad that they become irritable during the day, they can't focus in school and at home, and this can lead to long-term complications like learning issues and developmental delays. Also, with inflamed skin, they are more prone to secondary infection because the bugs around in the environment can go into the skin, causing further inflammation and infection. Children, when they get older, they get more self-conscious and embarrassed in school, at home with their friends because of their skin condition, which is quite visible to other people around them. And this can have an impact on their mental health and self-esteem. And so in dermatology, our aim is to make their skin as clear as possible for them to feel comfortable again and build their self-confidence. Food allergies are common, but interpreting them can be a nightmare. Now, unlike in adults, food allergies are particularly common in young children with atopic eczema, and we do think about them if they are not growing normally or if they've got really bad eczema that isn't responding to topical treatments. And there are actually two types of food allergies. The type 1 immediate IgE-mediated allergy, where you get the immediate reaction to food and also to other things. And in this case, you get urticaria or hives, swelling of your lips, your tongue, your hands and feet, also known as angioedema, and in severe cases, anaphylaxis, where you need to go to the hospital to get treatment. The other reaction is the type 4 delayed hypersensitivity reaction, where you get a reaction hours to days after eating certain foods. And in these children, you get a worsening of their eczema and you get other symptoms like gastrointestinal upset, which means they might get abdominal pain and discomfort, diarrhea and vomiting, and you see in these children that they don't seem to be feeding well and growing normally. Now, for food allergies, the tests we do in the hospital are skin prick tests or the blood tests, which test for the type 1 immediate reaction, not the type 4 delayed reaction. These tests should ideally be done in the context of a good clinical history where you get the type 1, not the type 4 reaction. The reason why clinical history is so important is because in children with atopic eczema, you do get false positive results, where the results show up as positive, but in actual fact, the children don't have a reaction to these foods. And so you can imagine what the issue is, because the last thing we want is to exclude important nutrients in these children's diet if they are not allergic to them. And so in pediatric dermatology, we work hand in hand with other services like allergy services and dietitians when managing patients with food allergies. I actually had my skin prick test done just to have a feel of what it's like to be skin pricked, and it was so itchy. And apparently I didn't know that until I started pediatric dermatology. New research has shown that we should actually be introducing these potential food allergens in children's diet at a young age in order for them to build tolerance so that they don't develop food allergies later on in life. Did you know that a lot of drugs we give in children are unlicensed? This is because we don't really have clinical trials looking at their efficacy and safety in children. And so a lot of these drugs are licensed for adults, but they are just used unlicensed for children. But from the years of giving these drugs to children, we know that they work and they are quite safe in children because children don't really have any pre-existing medical conditions like liver, kidney issues. And a lot of the time, the blood test results come back as normal when we monitor them whilst they are on the drugs. Children tend to be well looked after by their parents, majority of them anyways. And so if there's any issue, the parents are always on the ball and will let us know. Drug doses are often weight dependent in children, so we often need to weigh them in order to prescribe an effective but safe dose for them. And this is different from adult patients where the doses are pretty standard unless they've got, say, kidney or liver impairment. And the other positive thing about children is that they often are not on multiple medications, and the risk of drug interactions is very, very low compared to adult patients. The next thing I've learned is that everything you do takes time in children. And this literally can be anything from bringing them from the waiting area to the clinic room, to undressing them, asking questions, and doing a proper examination. I remember that there was one time I needed to examine a baby's mouth, just because they thought that there was ulceration. But I struggled to open the baby's mouth because every time I tried to go in with a spatula or a torch, the mouth was shut tight. They couldn't understand you. They thought you are going to harm them, and they started to cry. And I do get it. Everything is new and foreign to them, and procedures like blood tests and biopsies can be very traumatizing for children. We also need to think about the formulation of the medication. So for adults, majority of them can swallow tablets, so we don't really need to think about how we're going to give them the medication. And this is so different in children, especially young children, where we need to think about how we're going to give them the medication. Can they swallow the tablets? Or should we change it to a liquid formulation or even an injection? And last but not least, from my experience working in pediatric dermatology, I've learned the importance of putting a child in the center of our care. Children are a vulnerable group of individuals, and we shouldn't forget this, especially when we are bombarded with lots of work, referrals, and patients to see. Sometimes when we are busy, we do take shortcuts by just simply talking to the parents and getting the diagnosis and management plan in place and seeing the next patient right after. But by doing so, we often forget that the children are actually our patients, not the parents, though sometimes in young children, they might not be able to articulate what they are thinking. It is a whole new dynamic and consultation when you have children in the clinic room along with their parents, as compared to an adult patient where it's just one-on-one. I often have to actively remind myself that it is the children that I'm seeing, not the parents. And so I try to speak to them as much as I can to get an idea of what they're feeling, what their thoughts are when dealing with their skin. I still remember speaking to a consultant in clinic when a child didn't come for their appointment. Normally in adult dermatology, if they've not come for a few times, we do just discharge them from the clinic appointments. My consultant, however, reminded me a very good point. Children can't really go to the appointments themselves. We don't really know what's going on in the family, and so we should actually give them more time and maybe look into why they didn't turn up in the first place. Oftentimes, there may be issues at home. They might not be brought to clinic, not because they forget or they don't want to, but maybe because of something else that is causing this issue. I find my time in pediatric dermatology very enjoyable and fulfilling, and I think it's because of the people that I work with and also the patient group I see. Children are innocent and adorable, and the things that they do bring a smile to my face, especially after a long day at work. I highly recommend anyone trying pediatric dermatology out because it is a whole new world compared to normal adult dermatology. Thank you for watching my video. If you enjoyed this video, do give it a thumbs up and subscribe to my channel. See you next time. Bye bye.